drugs that work, and if you can kind of tweak things a bit and do it again and make it better, that's how we get more powerful results. So to answer your question, part of the program curriculum is actually to give them sort of handouts, sort of little booklets where they can sort of keep track of what they're doing and kind of set goals for themselves, set goals for their group, and to hold each other accountable. And to give you another example of how this accountability works, it even extends to the facilitators, many of whom actually benefited from the program themselves. So one of the facilitators was telling us that they're in this little grocery store. There's only so many places that one can shop in this area, and she has participants and family members of participants because now she's kind of the health person. They're looking at her cart and kind of auditing her cart, saying, why do you have a 2-liter Coca-Cola bottle in there? So kind of having that commitment that is voluntary, nobody's forcing people to be there. Having that done in a group setting, among people who care about you, you care about them, and having those people around you, in a sense, be accountable for your improvements, and you being accountable to their improvements, I think is really key. And if we just apply that to anything in our own lives, I think for me at least, that makes total sense. I need people around me to remind me and give me those nudges, to do the things that I need to do. In the back.
Sorry, Puna, quick question. Sorry.
No, go ahead.
Were the people in your study, were they employed, or were they not working outside of the home?
Both. So we offer different locations, different times, and certainly there are many people who it just didn't work with their schedule. But some people were working, some people were working part-time, and many of them did not have any form of employment other than formal commitments to family or childcare, things like that.
The reason I ask is because that is a big challenge. When someone's employed, they have to find time outside of the work hours to come home, cook meals, get the groceries, do all those things,
Yes.
versus staying home and not having those responsibilities, because that impacts the ability to go work out even.
Absolutely.
Even
for me. Yeah.
So that's what I was wondering.
No, it's a good question, and maybe one of the things we should do is actually try to put some kind of a graphic that I think we may have the data somewhere, but it's a good question. Yes?
That's a great question. I was thinking of that too. And then my other question was there any encouragement, or did you see this happening during your study about using online social network, about people creating groups to reinforce this? So is this something you offered, or did you see it happening? Is it something you looked at?
So I've done some kind of research in this area, and I also know, I think actually, sorry to keep picking on you, Hector, but your comments earlier that we need to kind of figure out how to use technology. We are in Silicon Valley to kind of amplify these effects. We've got to do it because it's happening in the reverse, right? How many of us know people who are experiencing some kind of psychological problem, and you can see it sort of playing out on social media, right? I'm sure that's happened to almost anyone. There's a whole discussion at major tech companies about health now, not in the sense of blood draws, but in the sense of mental health, conversational health, the health of the country. So I think it's just one of these incredibly powerful tools, and we have to figure out how to leverage it to kind of take some of these principles, identify what those nudges are, and to use those to either augment or even replace some of the functionality to make it more scalable and to make it more affordable. There are some companies out there like Omada, you know, that are kind of taking DPP.
So you didn't have a survey at the end asking feedback and means they may have used to get connected or to...
No, not sort of formally, but I will say that many of the participants, in terms of kind of communicating with one another, not only here but in the Middle East, created WhatsApp groups and Facebook groups. The health departments got the work.
So that's what I was
Yes.
looking for. So that,
Yeah.
as you said, in the future, if, to replicate
Yeah.
and get more power. And then my other question was that since you had 91% of female, I'm really worried and curious about that inclusion criteria. But then, if this is the case, if we have 91%, do you know if this 91% female were able to influence male in their lives, if they had male in their life? Were there any consequences on other people living with them or family members?
Yeah, so again, in most cases, you know, since we're looking at such a large population that's female, in most cases, women did not bring, you know, their significant other, their husband, for example, to the program. But anecdotally, we did see, and we did, you know, because we talked with them, we did focus groups, you know, we stayed in communication with participants and facilitators, and anecdotally, you know, because many of our participants were the ones doing the cooking, you know, again, a more traditional way of looking at household organization. If the person who's cooking the meals has kind of an epiphany and you know, starts to change, that's very powerful because that affects what the rest of the family eats, and especially the children. You know, we have all sorts of, you know, fun stories about not only wives influencing their husbands, but, you know, daughters, you know, kind of taking, I even witnessed this in one incident, a younger woman, a daughter, taking chocolate from her dad's hands in front of me, and this was in the Middle East, and that's extremely disrespectful to, you know, to kind of do that to your father in that culture. But, you know, she'd been sort of indoctrinated in a good way that this was actually something that was saving his life because, you know, he had very elevated blood sugar. So I think that there's drawbacks in the sense that the men are not in the course in large numbers, but the benefit is also that you're getting the people who are controlling the food supply and who oftentimes have way more exposure to the children. Yes.
But I think your question goes to a broader point, which is you're measuring the outcomes of the individuals who are attending the courses.
Yes.
But the broader hypothesis
yes,
is what's
yes,
the impact on the entire network?
Yes.
And you mentioned you partnered with the county. Was there like county level data or other sort of data? How can you look at the impact of that network?
So, yes, very important point. So what is the second and third and maybe fourth, fifth degree of that contagion? And you know, so if you think about the first level of contagion, it's from the node by recruiting her microclinic group. But then what is the impact of that group on the community? We need to, in the future, we're looking into ways to develop a trial that will enable us to do that and to sort of understand how many, you know, how much potency is in this intervention, you know, how many degrees away from the individual does the intervention impact. I will say though that with our partnership with the United Nations, which adopted this model for refugees, one of the things that was explicitly done was we called these microclinic participants ambassadors, health ambassadors, microclinic health ambassadors. And we said, let's not train them just merely as, you know, participants. Yes, you all care for each other, go back to your families. Let's actually train them as we would train facilitators. So totally lay people, you know, they have nothing to do with the health system. let's call them Microclinic Health Ambassadors, and let's send them back and ask each person to influence 5, 10, 15 people. And so, again, one of the examples, anecdotally, from the Middle East, using social media, using WhatsApp, some guy was just super, what you might call a super user. He created like a 100-person WhatsApp group and it was just blasting health information all day to his groups. And, he's a pillar of the community, I guess. I wish I had that many friends, but yeah.
So, go ahead, we're both our hands up.
Was your study designed to look at the social interaction, the impact of social interaction on the group and their behavior, or was it designed to look at social interactions influence on health outcomes?
So I guess it was designed to look at both. So we wanted to understand the impact of the intervention on those who had enrolled in the study and were placed in the intervention group as opposed to the control group. But at the same time, the study was designed in a way to detect the causal relationship between the social network dynamic and improvements in body mass index, blood pressure, weight. Now, I think there's another interesting level to your question, which is really about the intervention. So one might ask, well, is it simply the education that is working here, or is it the social dynamic that is working? And the social dynamic, we sort of looked at. We have a brilliant statistician from Harvard who did this study with me, and he did something called intra-class correlation, which really looked at a number of our studies to see what percentage of the clustering and the correlations within these groups are, or the weight trajectories, for example, within these groups are attributable to the social network dynamic. The second way that we looked at this was actually more specifically with our trial in Jordan, which again I'm not really presenting about, but I'm referencing at least, where we didn't have an intervention group and a control group. We had an intervention group, a second intervention group, and a control group. So the first intervention group was sort of saying, okay, let's dial up the social dynamic a bit and do the 4M education procedure. The second education group was, let's dial down the social dynamic a bit and do the education procedure, and then let's do the control. And so we saw in that one that the education was present in both, but the one that had a little bit more of the social dynamic, people tended to do better. And so, again, we have the same problem of cross-contamination in that, and adherence to the exact protocol. It's hard to get people not to socialize in a group setting like this, especially in the Middle East context. But that's kind of the way we try to delve into that, more of a detailed view of what is actually causally related here. But Bonnie, did you have a question then?
Yeah, mine was just again for the public health framework,
Sure.
for the population health, in terms of, I guess I was just thinking a little bit about sustainability and scalability. Think about that a lot with a lot of programs, because we have a great program, and how do you think sustainability up front, because it's generational and population, and so just have you thought about that?
And you don't mind just repeating the question, because we can only hear you at the
Oh, right.
Zoom. So just if you could just briefly.
Sure. So a question about sustainability, and Hector, was your question totally different, or was it okay? So the way we kind of designed this, and you can see this is a longer program. There are quite a few sessions. We've been toying around with different versions of it. So shorter program, just 8 sessions. The sustainability aspect of it, if you think about it, is kind of what are the inputs, specifically what are the financial inputs? The biggest financial input would be the person, the warm body, who's going to sit and who's going to deliver the program, facilitate it. And so what we sort of talked about with kind of our local health departments that we work with, or the Ministry of Health, in Jordan or Mexico, is, you can have the same healthcare worker, for those 2 hours that she or he is doing this program, you could have them, see a few patients. But if you get these 15, 20 patients and you empower them with this information, they're going to become better patients. But especially if you're a public health department, you're probably going to have less people coming through your doors with problems that are costly. And we cite the studies that we're all familiar with, which can be summarized, an ounce of prevention is worth a pound of cure. So we designed the program really to be that way. The main cost is for a public health system to say, okay, I'm going to allocate some time for my staff to facilitate this, and we're going to we're not just going to lecture the community, we're going to make them kind of partners in this community-wide propagation of these important health principles. And one of the things that is sort of outside the scope of the study, but a lot of people in the community got involved. The local radio hosts, talked about the program, and knew people in the program. 5 acres were donated to create a community organic garden. Corner stores started changing what they were offering, what they were selling, and we did a little study on kind of supply and demand, to understand how things change. So the way I sort of see it is, if we're going to change things, if we're going to stop people from smoking, there's got to be kind of this top-down, bottom-up thing that's got to happen. And for me, this is the bottom-up piece of it, the kind of activating social groups to change those norms and to kind of, make certain things not okay anymore. But then also, we've got to have a conversation with those from the top down to change policies, to change, maybe the way things are taxed, to change regulations, and to have that full saturation. And only then, I think, can we really, really have the massive change that we need. Hector, did you have?
Oh, I was just going to go back to like the secret sauce about commitment and trust, and
Right.
What's there. And one thing that you guys made a decision about in your design choice was to have people self-select
Yes.
their teammates or
Yes.
people who are in their group. And you see other models of behavior change where it requires some distance from people that
Yes.
you know in order to get an objective perspective, like Alcohol's Anonymous
Right.
or Weight
Absolutely.
Watchers or whatever. Because that lack of familiarity, maybe we'll learn something new. We're not embedded in our network so much that there's negative reinforcements in that network. So, I think it's bold that like you take the whole network and try to change it, but at the same time, I think it's also risky because that network is harder to break through if it's reinforcing negative behaviors. So I'd wondered what the design choice was. Like, you guys obviously thought about this a bit, like whether to randomly assign and have people mix it up, or whether to try to take advantage of trust. So I think about this strong tie, like for trusting relationships and what they're good for, and then the weak tie, which other programs seem to take advantage of this weak tie phenomenon because it's about information and how to do things.
Yes.
And it's not like with all the baggage of the strong tie.
Yeah, no, what's that?
You served me the question.
Oh,
Just
okay, yeah, sorry.
Design choice.
Okay, design choice of
Weak
intervention.
tie or strong tie? Why do you guys choose strong
tie
ties?
or weak tie? No, we're not talking about garbage bag ties.
Yeah.
No, that's a really important question. And I would say in some ways, through our various projects, experiments, we've kind of explored different ways of thinking about this. Let me talk a little bit about your question more abstractly and then concretely here. More abstractly, I started by telling you kind of a personal story. Like this idea came from an observation, really, that this is what people were doing anyways. They were sitting down to a meal, influencing what they were eating. They were sharing a glucose monitor, because somebody couldn't afford one, so it's kind of being shared in the whole family. They were splitting pills, sharing medicine. So it was almost as if this mechanism for influencing behaviors was already there. And so kind of by harnessing that and trying to manipulate it in such a way where, instead of bringing somebody into the program and having that person, learn that soda is bad, for example, and then she goes back home and she takes away the soda and there's a revolution at her kitchen table. But it's a little bit easier if, her sister, the person who's at dinner anyways, was with her in this program and learned about how much sugar is actually in a bottle of Coca-Cola and can actually back her up a little bit. It just creates a little bit more reinforcement that I think is important. But there is also the dynamic, and this works in different ways in different places. There is the dynamic that you are exposed to a lot of people you don't know, because some people, aren't able to bring a big group, and there's other people in the class. It's not just you. It's 5, 6, 7, 8 other groups, other individuals, and so you kind of have a little bit of that weak tie dynamic. And so both are kind of happening at the same time. People you don't know, maybe the negative aspect is that, maybe you're a little bit more cautious about what you disclose, but you use Alcoholics Anonymous, which is a great example where people are very vulnerable, but they're willing to kind of share a lot with kind of a trusted group of people who are going through the same thing. So we're kind of trying to do a little bit of both in this context, and maybe it's because it's diabetes or cardiovascular disease or weight loss that we're targeting, where this combination works. Maybe it doesn't work as well in the Alcoholics Anonymous case or substance abuse case, which we really haven't looked at. But great question.
But I think it's, how do we get them to change behavior? I understand the influence, but someone who's highly educated knows that the soda's bad for them. They know it has plenty of sugar, but they still want to drink that. That might be their vice. They have to be willing to have some willpower to an extent. And how are you changing the behavior? Are you going to, in that person? Peer pressure is for so long and it helps. My husband, I cook him a great meal and going through, but I don't know what he's doing during the day on what he's eating. So there has to be some change in habit himself. You can put so much pressure. Are you guys following up so many years later to see what has changed? Kind of like your question there. The peer pressure is only for so long, but how do we get them to actually change a habit?
Yeah, so we don't have like 10-year data, unfortunately, but we do have some long-term data, even 2 years-ish, and we saw, for example, in one of our studies that an A1C drop of 1 point was sustained for 24 months. And so again, this gets back to what is the mechanism. Well, if people are changing their behaviors with respect to these 4 M's, if they're changing what they eat, if they're changing how much they, if they're changing their meals, if they're changing their movement, if they're changing the way they're self-monitoring.
But is this staying? That's after the study trial time long enough.
Yeah, so again, the longest we've been able to look thus
The
far
2 years, okay.
is the 2-year mark, which is significant, because I mean, what you often see is you see this, kind of weight loss crash, and then, you have a rebound, and oftentimes people get discouraged actually, and so they just, keep climbing. So I think the fact that we see generally a trend like this is really interesting and important, and it requires, I think you make a good point. I mean, we need more studies, and I hope other people in this room, can take part in these studies, whether you're, hosting one at your health department, or, at your university, or with your patients. But no, it's a very important question. I think, the key thing here that we're seeing, though, is that people are changing their behaviors, and it's not just, some people, yes, they get a bad set of medical tests. Wow, you see their behavior change. I mean, it's amazing. Just getting that monitoring is something that's very powerful. But you also see people who really want to change. I mean, one of our kind of star participants she was really in bad shape, and she was saying, you don't know how many doctors I've been to, and nobody believed in me, nobody told me that I could lose this weight. And what was really key for her was a group of people, some of whom she knew, but a lot of whom she did not know well or did not know at all, who kind of formed that support, and she saw them changing, and it gave her kind of the courage. And I mean, she needed to lose weight to have some kind of a medical intervention, a surgery, and then she sustained it. She didn't just have this. She didn't just lose the weight, have the surgery, and get it back. She sustained it, and I just saw her, a month or 2 ago, 2 months ago, and she sustained the weight, and that's after almost a decade. So I think, the social element is not the only element. A person's got to be willing to change. You can bring a horse to water, but you can't make them drink, sort of thing. But it is a key ingredient to change. Knowledge is a key ingredient to change. Integration with the healthcare system. Having patients be empowered to ask questions of their doctors and nurses. That is a key ingredient. All these things are part of this pill, and we've got to figure out how to make it better, how to amplify the things that are working in that pill, and how to turn up the volume on all of these.
Just a small question. So the curriculum that you showed us, that was probably developed and formed from your experience at Georgia,
Yes.
right?
Yes.
So you took the ingredients that you thought were key and put them into this curriculum, and then
In collaboration with the local community, so
Got it.
kind of through this iterative process with them, and getting their advice about what makes sense.
and it's the same group every week?
Yes. Once you enter the program, it's kind of you see the same faces. And, yeah. Again, some people some people you don't know. To Hector's point.
You can finish your slides and then we'll continue the conversation afterwards. I don't know if you're-
Sure. I mean, I think, I think we're at pretty much the end. I would just say, we've piloted this in different places. We've also, we asked the question initially, does this work? And we did kind of, some baseline, 4-month study. And then we asked, does this work in the long term? We did kind of a 2-year study. Then we said, okay, we got to answer this question about causality. Is this working because, some kind of macro change has happened in Jordan, for example, where, the king said, we're going to ban soda, and, all of a sudden we're seeing people improve, or is there something really causal going on between this program specifically? So we did the randomized trial in both Jordan and in Kentucky. When we moved to Kentucky, asking the question, does this only work for diabetes in the Middle East, or can this work for cardiovascular disease, obesity, type 2 diabetes in white rural, Appalachia, Kentucky? But then we also, asked, can this work for an infectious disease? And I know that that's not the focus of the group today, but you know, on a remote island in the middle of Lake Victoria, my colleague who's pictured here from UCSF, you know, took the model and kind of adapted it for HIV/AIDS